Hi, my name is Peter. I'm a emergency medicine resident based in Stockholm, originally from Denmark, and I want to talk to you about today a really important topic, which is basic and advanced airway theory and management for the Scandinavian emergency physicians. We all know that Scandinavia is a bit different when it comes to especially airway management and emergency medicine in general than the rest of the world. And as I alluded to in some of my blogs, there's a high difference between Sweden and Denmark as well, because of culture and health systems design. What I want to touch on in this lecture series, which will be around 6 to 8 hours, is that I want to give the emergency physician of Scandinavia an overview of this topic. Because we are not the ones doing the intubation in Scandinavia, but it's still in our curriculum to know about this stuff, especially as a team leader. It's important to be able to make judgment on the airway, whether or not to call anesthesia, whether or not, and when they are there, when they're at our bedside, to engage with them as a partner in the discussion of what drugs to use, what kind of intubation techniques is the best, what kind of approach should we even intubate this patient. We should probably not, in most Scandinavia contexts, be the ones doing the procedure, and even probably not making the major decision in this, but we are part of the team, and we're part as team leaders, so we need to be able to know quite a lot on this area, and that's what I'm trying to give you here today in this lecture series. I've already made a blog on this, and all of these videos are in English, and the reason why they're in English is mainly because so that all of Scandinavia can actually listen in if they want to, if they feel like it. And I've been encouraged from some of my Swedish colleagues to do them in English instead of doing them just in Danish. The blogs are though still in Danish, and if there's any international audience, then that's a problem. That's why they can listen to these English videos, but for the Scandinavian audience, I believe that most Scandinavians will be able to at least understand most of what I'm writing in the blogs. So the blogs are on akutmedicinen.dk if you follow this link. And but I always like to do these video series so that I can go into nuances, or things might be easier to explain in words rather than spoken words, rather than in written language. The main thing in these videos is that I don't want to offend anyone by these. I want education to be open, especially if it's something that is in our it is in our curriculum, which it is, especially in Sweden, but also in Europe. We need to know about these stuff, and it's really quite hard to get at through the FOMED literature. Through the literature, because at least in Scandinavia, the anesthesiology specialty is sitting quite hard on it, and for good reason, for a lot of good reasons. But I think with us as team leaders, we need to know a lot of this as well, so that we can at least engage, and in some situations maybe move towards doing PSAs, and in very specific situations, not generalized to all of Scandinavia, but in specific contexts, there may be a role for us to do intubations, but not in general, not something that we should do, I believe. Nevertheless, here's a long lecture series on the theory behind it and how to do it if we are going that way, and especially so that we can be team leaders and partners with our anesthesiology colleagues, so that we can give the optimal care for the patient. I have a few disclaimers before going into this video. I'm not an anesthetist. I haven't intubated anyone since med school, and well, my experience with advanced airway problems and also basic airway problems comes from my clinical experience. And I've done a few intense courses here in Sweden with simulation training by anesthesiologists, by emergency physicians. When making this disclaimer, it goes without saying that you should not apply any of this tomorrow in your emergency department. You should always consider the references I'm putting up, consider whether what I'm saying is good or not, or true or not, or evidence-based or not, and whether it fits into your context and your system. This is mainly a framework for how to understand and how to get an overview of this topic. That is the purpose of this video block. As you might have noticed, I speak quite slowly, and I these videos of mine usually takes a few hours, sometimes 5, and I expect this one to be as long. So please go ahead and adjust the speed on your YouTube channel, on the YouTube video, so that you can get on with doing other stuff than just listening to me speaking about this topic. I want to give a shout out and a big thank you to a lot of these course instructors that I have had the pleasure of being taught by, and also Emilia and Jonas from my own clinic have been really great at going through, especially Emilia going through cases with me, and Jonas has done one of these courses with us where he taught us what he knew about this area, and this has been hugely impactful for me in this area. Before I go into the primary lecture here, I want to just highlight some of the foment that's out there about this topic. One of the reasons why I'm doing this topic is that as an emergency physician, without going into anesthesiology, it's quite hard to collect all of the references and to get an overview of the topics that we need to know about, especially as it's sometimes, especially in Scandinavia, considered anesthesiology territory, and it's kind of hard to get at in many ways. So here's a few highlights for those of you who like to read up on it on foam, or read blogs, read videos about it. One of the main ones is Scott Weingart and Rich Levitan. Scott Weingart has the EMCrit, and Rich Levitan has a few videos on SMAC, which is now called CODA. And then Josh Vargas has his PalmCrit on EMCrit blocks. And they have, I will list some of the terms here, which I might explain throughout this video. These are either coined or usually talked about by these people. Then you have Ruben Strayer and his EM updates. He has a few, but really, really high quality videos on back valve masking, on the procedure sedation trilogy, and he's spoken a lot about ketamine, and he's a big believer in rocuronium instead of succinyltonium. He has a lot of debate videos about that as well. But I would suggest, if you are interested in the intubation technique and nuances, then he has a great video on SMAC called leisurely laryngoscopy. One of the gurus in this area is George Kovacs. And George has I'm not sure whether it's only his. I think it's a collaboration between him and a few others. They have what's called the AIME, AIME homepage, and they have a free ebook that is continuously being updated, called the AIME book Infinity version. And if you want a Bible for the emergency physician about airway management, I think this is one of the great suggestions. He's also talking a lot about the psychology, about difficult airway, and he has a lot of videos on what you call EVLI and micro skills on YouTube and on AIME, and on AIME's YouTube channel, and on Weingard's EM Crit. He's been on a few times. He's also been on EM cases, among other on burn victims and burns and inhalation injuries. And so he has a lot of great stuff on these other platforms that's worth checking out. Then you have a rather unknown, probably, name, but Eric Chappelle. He's made very few very high quality videos on his YouTube channel, and the best ones, I think, are about this very topic. He gives a very concise overview in much less time than I would ever be able to. So please check those out if you want to like have a really overview about airway management, advanced airway management. Then you have one of my favorite foamators, First 10 EM, Justin Morgenstern, and he has a lot of videos about this, and I'll just list a few of them, which I will be using and referencing. Then you have Rebel EM, Salim Rasay, making great videos, making great blogs about this topic as well. So he has a really great blog about hop killers. Hop killers, which we will get into, is hypoxia, hypotension, hypoxia, and pH problems during intubation, and how that will kill you if you don't adjust your management and your medication choice and dosing. But Scott Weingard has made these videos called the laryngoscope as a murder weapon, but they're quite long, and if you want a summary of those, Rebel EM has made a great summary. And then you have some of the anesthesiology foam. Life in the Fast Lane is intensive care, emergency medicine, so that I put it here, but it might as well have gone here on the emergency medicine side. Then you have this homepage and YouTube channel called Propofology, which is a great resource for advanced airway management and other topics anesthesiology-wise. ICU Advantage is a YouTube channel which does the same. Dr. Gallagher's Neighborhood is like an oldie but goodie YouTube channel that has really high quality content about advanced and basic airway management. They're concise, and they're probably one of the best resources for beginners in this area. Then you have Interarrest. This is a Swedish site based in Lund, but many of their videos are in English, and I would encourage even Danish speakers to check them out because they're really high quality. They're Scandinavian, and they use our kind of framework for explaining things in a way that might not be explained in the same way in more English-speaking countries. And then you have Narkosguiden, which is a Swedish site that is also really good. I wanted to put down here the last one, I think, which is the Vortex Approach homepage. We'll be talking a lot about the Vortex Approach. They have a YouTube channel as well with a few interesting videos, which I also encourage you to check out. But the Vortex Approach homepage is really good and worth checking out. It's worth noticing that the Vortex Approach is not evidence-based. It's a really cool and great concept that takes a lot of the human factors stuff that I love to talk about, and I think it's a really good concept if you have to remember one thing about airway management. That is the one, I think. But it's not evidence-based, and that's why to balance this out, the FOAMET here, I want to balance this out by showing you some of the maybe main resources that are more academia. Last one is Martin Tubin. He's written a lot about physiology of airway management. I think he's a pulmonologist and intensive care doctor. He's been on EMCrit, and during the COVID pandemic, he's talked a lot about how basic physiology is really important. I've written up this article of his that gives this argument really well. Okay, here it comes. These are some of the more official sites and organizations that you might want to check out. I put up the American and the UK versions of managing difficult airways. I've also put up this Difficult Airway Society, which most other societies references. This is like the main one probably if you want to know something about advanced airway management. I've put up the Danish and the Swedish ones. The Swedish one has a recommendation that is very much like the vortex approach. So please check that out. I haven't brought it along because I like the vortex approach better, but I think it's really close. And then I put up also the tracheostomy.se. I'll be talking in the end of this lecture. I'll talk about tracheostomies and tracheostomy emergencies, because this is an important topic that I was not taught, and that I've come across a couple of times, patients with these problems, and where I've stood in a lot of problems with this with this topic. So that's why I'm going through this as well. Then I put the ERC guidelines as well, which are like great in all the CPR area of airway management. Okay. Before we head into this, I just wanted to recap some of my earlier videos about what we call epistemiology, which is an area I'm really interested in. And I've recently found a podcast that is as interested in this as I am, called A Bedside Round. Adam Rotman. It's an internist podcast, but I really encourage you to check it out. Their episode 50, which is called I Know Nothing, goes through the epistemiology part of this. So epistemology is like when you're sitting in front of a patient and they ask you, how do you know this? Well, then you have a few pillars, and it can be argued how many pillars there are where we gain our knowledge from. But in general, before heading into this lecture, I just wanted to remind you that I will try to base a lot of this on evidence-based medicine, but a lot of this is also experience-based medicine, and also a lot of it is mechanical-based medicine, physiology. And it's really important to not get bogged down by, oh, this isn't evidence-based. Well, we should look at evidence-based medicine as a tool, not as a definite rule of everything. And there are certain areas that probably cannot be investigated only with evidence-based medicine. We need to apply some other epistemological themes when we're treating patients, and we should not look at one of them as superior to the other. In general, they may be superior in specific areas, but not in general, and we should use all of these. So what I usually talk about when I talk about epistemology, I talk about, well, there's the mechanical physiological argument. Well, I mean, it makes sense that we do thrombolysis on this patient because it has a blood clot. Blood clots are destroyed by agents that dissolve blood clots. So thrombolysis makes sense from a mechanical perspective. And then we have empiricism, and that was experience-wise. And you can have population experience, evidence-based medicine, or which is more systematic. You have non-systematic experience, which is your own experience as a clinician. And then I guess I always put traditionalism as well, because sometimes when we say, how do you know? Well, we always did that. We've always been doing that. And that's, just to put it in there, that's probably the worst. Or if we need one of these themes that is bad, that is probably one of those that are a bit bad, because we shouldn't do things just because we've always done them that way. There might be some wisdom to it though, but the argument should not be just because we've always done it. So as I alluded to, there are no absolutes here. Oftentimes when you have a patient, you need to do one thing, which is something that, like in complex systems, you need to, and when you're talking about non-certain data, you need to do a thing and then see if it has what kind of outcome it has. And if it had the wrong outcome, then you have to do another thing. That's like what Scott Weingart talks about in his OODA loop and bread baking lecture. So even though we can talk about how do we know stuff, like we have to try some of the things as long as they're not irreversible, and try them and see if it works, and if not, then try another thing. We made a podcast about the problems with evidence-based medicine. I just went through like the mechanical physiological argument, and all these arguments can have problems with them. We know that our own experience is biased by selection bias. We only see a certain amount of patients, certain group of patients, and we see an incomplete picture usually. And if I move to another country, which I did, then I'll suddenly see a different system, see a different area of whether I'm urban or I'm suburban or in rural areas, different populations. So our experience is really, and some of the things that we have experienced are general, but a lot of them are not, and are very system specific. So it's really great to have this, but there are caveats. Evidence-based medicine, in our podcast, we talk about the benefits and the problems with it, and some of the problems is that it's population-based, but what happens when you sit with your own patient in front of you, and how does this apply when 140 patients, especially if they're young and not the same population, how does this apply to my old patient in front of me with his or her values and so on and so forth. And then there's the problem about, which I've talked about in lower blocks, that Ioannidis talks about as well. John Ioannidis talks about, evidence-based medicine has been hijacked. There's no, the regulation has been degraded and so on. And people like Vinay Prasad and others are talking a lot about these things these days. Ben Goldacre, and this is an incredibly important argument for not evidence-based medicine, but because optimal evidence-based medicine would be great, but this is not what we have. We have a flawed system because of the dysregulation and so on. So evidence-based medicine has been hijacked, and that's why we sometimes, because of, among other, publication bias and publish or perish culture and so on, cannot really rely on a lot of those things that we see in evidence-based medicine. And the mechanical and physiological argument we'll see when it comes to vasopressors, vasoactive agents. Well, I mean, you can theorize as much as you want about the receptor profile and so on, but in the end, usually our knowledge of the general physiology doesn't always apply to the individual, especially if the general knowledge comes from the healthy body and this is a sick body, especially if it's an old polypharmacy body, where things becomes more complex. Sometimes it's also that we don't know the theory, that maybe when we do thrombolysis, it didn't work. Why doesn't it work? It should work because we should remove clots. Well, maybe there are collateral arteries that explains some of these problems we have with thrombolysis. Maybe the clots are from the heart and have been there for a long time. Therefore, they cannot be. What I'm trying to say is a lot of the arguments don't necessarily hold water when it comes into, might make sense, but in a complex body or complex system, the simple explanations that we have from physiology do not always apply and cannot be extrapolated in the way that we sometimes do. But we have to use all of these tools in the toolbox to actually be able to make decisions. Otherwise, we would not know anything. I just wanted to make sure that you know about this, because when we go on and we argue why would we do stuff, well, it's usually from one of these things. Okay, so this is position of this talk. First of all, I want to go through why is it important to have this lecture on advanced and basic airway management, and a bit about the argument of whether emergency physicians should be able to intubate. Then I'll go through the basic A management and go through the vortex model, and then move on to the advanced A, which would be endotracheal intubation, ETI, and how to do an RSI. And then in the end, I'll talk a bit about some cases, some difficult patient scenarios, and then tracheostomies, and a few topics that I haven't gone through in depth. I will go through here as well. Okay, but first, let's talk about why this is important. So I'll just try to talk briefly about some of these topics. Should emergency physicians intubate? The goal with intubation, what is that? And how do we make the decision to intubate? So let's jump right into the beehive. Should emergency physicians intubate? Well, when it comes to any procedure at all, it all depends on competences and on the context in which we're working, and how that interacts with our main goal, which is the best for the patient. For instance, are we in extremes, like are we in rural Africa and you have someone with an A problem? Well, then the ones with the most experience should intubate, right? And if no one has the experience and the procedure is too dangerous, then it's probably better to just try to wait it out. But when push comes to shove, and you have to do something, well, then you have to do it. So these are some of the factors that you have to factor in always when you have this discussion, I think. I've in the next slide I've written down some of these, so let's go to those. So should emergency physicians intubate in Denmark and Sweden? And I guess some of the things are like the airway belongs to the patient, right? There's no specialty that owns anything about the patient. Then there are certain specialties that are certainly expert at certain things about the patient, and usually those are the ones that should do it. But many times those specialties are not there when you really need it. In Denmark and Sweden, we have been really fortunate that anesthesiologists are almost always there when you need them. And in the cases where they're not there, for instance, at my hospital, sometimes there could be 5 or 6 codes at once, and some of them might be cardiac arrests where they need an anesthesiologist, but usually they can find a way around how to prioritize or be two places at once, or manage the ones that needs it the most. But you can imagine a scenario with lower resources where you actually need to know a bit more than the usual, because no one is coming. And part of that is I think somewhere around there lies an argument for us to be able to know more than just basic airway management. We need to know about advanced airway management as well. That doesn't mean that we have to use it on a routine basis. We need to practice it if we want to use it, but we shouldn't necessarily be the ones doing it on a routine basis, I think. Again, it always comes down to what is the best for the patient, and in a scenario where you're on a hospital where anesthesiologists can be called, they are expert at it, well, then they are the ones who should be called always. Because I'd rather be intubated by someone who's done this before, who, as long as they know about like the difference between the operation room and an RSI, and almost all anesthesiologists I've known and worked with know this. But every once in a while, we do come across a young or new anesthesiologist who wants to do what they are always done or are most comfortable with, using normal dose propofol, for instance, in a hypotensive patient. And that's where we might be able to at least discuss their airway management with the patient, with the anesthesiologists, and being able to have more knowledge in this area. I think it's important to be able to, as team leader, to have this discussion with our colleagues. I think it's slightly sad that we have pivoted so much on whether or not we should intubate in emergency medicine, because as John Hines, an intensivist, said in one of his lectures about cracking the chest in thoracotomies, before going to the patient's bedside and doing these things, we should ask ourselves: are our intentions honorable? Do we, as a specialty, just want to intubate because it's a cool thing, it's a cowboy thing to do, or do we want it because that's what the patient needs? Those are two very different things, and sometimes they overlap. And I will admit, a lot of the things that we do are something that we do because we also think it's fun, but it shouldn't be the primary thing. So these are some of the main topics or arguments or discussion points I think in this discussion that we need to be aware of. And what I say in this podcast, in this vlog, video lecture, is my own opinion. It's not the opinion of any organization in Denmark. It's not the opinion of Akut Medicin. It's my own opinion. But I try to make it a bit more even through the research I've done. So in short, I think emergency physicians should know how to intubate, and when push comes to shove, in certain situations, we may need to. We have to practice if we want to do that. But I also think that there's a lot of things that are more important than knowing intubation, especially when you work in Scandinavia, where anesthesiologists are right next door, and I think we make a much better investment by knowing how to lead our team, knowing how to engage in these discussions at a respectful level with our anesthesiology colleagues while they handle the advanced airway. There are some things from one of the courses by Teresa Järv, an emergency professor at Karolinska, who showed me these, and I wanted to just give you an overview of this. If we should intubate, what does it require as emergency physicians? Well, just to gain proficiency, it seems like in literature, there's quite a wide literature here, and it's not really new, a lot of the literature, but there's this really classical curve from Conrad et al. In 1998 that says that, as with a lot of other things, when we're learning, in the beginning we're not very proficient, and then as we gain experience, we become more and more proficient. The proficiency here is in the rate of success, not first pass success, just success, like getting the tube in It doesn't, but not necessarily first time, which as we will talk about, is really important. But gaining this kind of proficiency seems like 75 attempts, 60 attempts, something like that. Then you have the skill set down. Non-evidence-based sources will tell us from Karolinska and from other areas that, well, the first 20 people think that these are hard. Next 60 or 80, that's where they usually feel this is okay. Some of the studies tell us that going up to almost 200, 220 intubations, it will take to actually be proficient at it. And it also depends on what we rate as proficiency. Is it first pass success? Because then I think this would be a bit higher, but maybe not in the age of video laryngoscopy and hyperankulated plates. Maybe not. So it's hard to say, but we need to know that we need a certain amount to gain the proficiency to do this. And then, well, we want actually to do first pass success, because if you don't get the tube in on the first go in an emergency medicine patient, an emergency department patient, then we know from studies that the complication risks are increasing with each attempt above 1. And so some authors have suggested that our first pass success when doing intubation should be 95 to 100%. It's important to notice, as I just said, these studies were done with direct laryngoscopy and not video laryngoscopy, not Bushi, and not hyperankulated plates. So we have a lot of help today that makes intubation attempts by us maybe be more achievable, actually. But what isn't a successful intubation? Well, if you ask Scott Weingart, he has this -1A principle, which is, I think, important and nails it. It's definitive airway, which is a tube with a cuff under the vocal cords. Sound, hypoxemia, and hypotension. So without any hypoxia or hypotension during induction or after, and also in the first attempt. So first pass success -1A. And I think it's not Weingart, it's one of his colleagues who's like coined this term, but he uses it a lot. So then Malin Johnson Fagerlund, a anesthesiologist in Karolinska, said that we shouldn't try. We need to succeed. Vi ska inte försöka, vi ska lyckas. That's kind of like the first pass success. We shouldn't, when we go into the intubation mode, we should not think, oh, we'll have a go at this and see if it doesn't matter. If it doesn't work, then it won't work. Well, that's not how to approach intubation. We should do it because we think we will succeed in the first attempt, and that's how we should optimize it. That's how we should think in the first attempt. And then my boss usually talks about finding the hole. That's what success looks like. You have to find, or that's what you need to do during airway management. You need to find the hole and get a tube in, like as simple as that. It's important to notice, like, if we as emergency physicians should ever need to do this, Scott Weingart's take on this is that we should limit the variability as much as we can, because we don't have enough attempts to do all the different things that anesthesiologists can. So we have to practice one approach, which he suggests, I think, is video laryngoscopy with the Bushi, and just train that one approach so that we're expert at that one approach in every situation, instead of using a lot of approaches. I think I agree. I would agree with that. If we should do this, but as I said, I don't think in our context right now we need to do this. Not in most hospitals I ever worked at. There might be certain hospitals all over Scandinavia there might be a lack of anesthesiology colleagues to do this, but I think in most situations we don't need to. Then that was gaining proficiency. How do we maintain proficiency? And here there were some great studies here quoted down here. So it's quite hard to find how many intubations we need per year to actually maintain this proficiency, but one simulation study suggests that 3 intubations per year or supervising 5 per year. And then you can ask, how many are done in how many of these advanced airway management patients do we have in Sweden or in Denmark for that matter? But maybe it's a bit different in Denmark because the population is a bit sicker in my experience because of a patient cannot just walk into the emergency department. We have closed emergency department where you need where you need to be sent by a doctor there. So in Sweden it's like 2.4 out of 1,000 visits. And if you calculate that into how many emergency physicians work at these places, then it's like 2 intubations per physician per year. And that's just maybe shy of what was achieved up here. But so even if we wanted to do this, it's right now, as it seems, it doesn't really seem like we have, or we might just barely be able to. But we would in a thing like this, we would probably have to be even more practiced and maintain with even more intubations if that's what we needed. And then there's the problem with what you call creep. Like if I suddenly can intubate anyone I want, then my indication for doing it might be increased. This is what you call creep. And which might lead to us doing more intubations, but I'm told that some of the studies from, I haven't checked this up myself, so take it with a grain of salt, but from some of the courses that I attended, they told us that in the United States, in some of the countries where emergency physicians do intubate, it seems like cardiac arrests or intubation is one of the procedures where there is most cardiac arrests as well. And this was from one of our professors in Karolinska who told us this, who works with cardiac arrests literature. So it seems like there might be some creep going on when you compare Scandinavia to the United States and when you intubate and what the indications are, and that it might have detrimental effects on some patients when you look at it at a population level. But this is a speculative argument, but it's important to take into account in this discussion. So why should the Scandinavian emergency physician actually learn this? Well, there's the official approach, I think. We need to learn this because of e-beam, and if we want to work internationally, or if we want to do when we do our anesthesiology rotations, we need to know these things. So that's the bare minimum. Then I guess there's certain professionalism argument as well. So we are team leaders and we are also partners, and we need to be flying ahead of the plane. We need the anesthesiology intubation thing. I think for team leaders should not be a black box. We need to be able to know at least the risks and the factors that goes into the decision of intubation, and what kind of factors that should be adjusted when you have a patient that is in a bad way. And then the argument of whether you're in a really dire situation where anesthesiology isn't there, then you always want to be able to do something. And FONA, front of neck access, or emergency tracheotomy, cricothyrotomy, sorry, a hole in the neck is really something that has a success rate of, I think, is 1 in 3 in the literature. But every doctor should know how to do this. This is taught to every doctor. But intubation rate, especially with video laryngoscopy, probably has a much better success rate than that for most physicians. So in dire situations, maybe we should teach people to use a laryngoscope instead, and then the argument is like, do what you do the best in a hard situation. But I think in dire situations, we might, as emergency physicians, be the best shot. But dire situations don't come often, and in Scandinavia, where anesthesiology or other experts aren't available, so this is a minor argument, I think, in Scandinavia. Then you have the new territory argument. Well, PSA, procedural sedation and analgesia, is something that we might be able to do as emergency physicians. They've done it in Lund with atrial fibrillation conversion, and they've done it in Sundsvall, also in Sweden, where they regularly do PSAs. A lot of places do PSA, procedural sedation, for orthopedic stuff, or for like hernias in surgery, and usually it's done with very, very much traditionalism, like 5 morphine, 5 diazepam. So sorry, 5 milligrams of morphine and 5 milligrams of diazepam, and without considering whether or not this might go into a advanced airway problem. So I think this is an area where we might be able to increase the security for patients and the quality of for patients if we are allowed to do and know the theory about PSAs. Why aren't I doing a lecture about PSAs then? Well, PSA and advanced airway management goes hand in hand. If you know advanced airway management, you know how to manage PSA, because you always have to do your PSA preparation as if you were going to end up in an advanced airway. So we're going to go through the same theory here. Also, I'm not doing that lecture because Ruben Streo did a great lecture on this, the PSA trilogy he's done on EM Updates, his homepage there. All right. So I hope you've been motivated now to listen on for the next couple of hours in this lecture when we go through the theory of this. Oh yeah, just to show you, this was the study, air quotes probably around study, because it was a what you got, pilot study, I think you would call it, or a proof of concept study, where my friend and colleague Eric Driver from Lund, emergency physician, he and his team wanted to see whether or not emergency physicians could do propofol sedation on atrial fibrillation patients, and they did it without major complications, and they did it in a really safe way, I think. And I think this study, what was amazing about this is actually the comments in this. So go to Läkartidningen and try to look up the comments, and you'll see this entire discussion that I just went through unveiled with strawman arguments and with fear and with from both sides. So I won't go into this anymore in this lecture, but I think it's important to acknowledge that there is a tension here, and that we always have to do what is best for the patient, and there might be a space for us to do propofol or sedation with ketamine, which is already done really safely pre-hospitally. But we should always, but in most situations when it comes to intubation, that is not something that we need to do, I think, in Scandinavia, because we have anesthesiology really close by. Okay. Why do we need to intubate a patient in the first place? That's what I want to go through now. So this is the chain of airway of oxygen delivery, and it starts with air outside of the body, and then it goes into the alveoli and all the way through our capillaries and so on until it comes to the mitochondria. That is what we want to achieve when we have a airway obstruction and we want to make the airway open. It's all the way through. There's an important concept to know about here, and that's the this oxygenation curve here, where you have when does a patient actually desaturate, and how does the affinity of oxyhemoglobin becomes different with lower concentrations of oxygen. And it's important because in saturation wise, your it's okay to when you're in the top around a saturation of 93, 94, something like that, then it's pretty okay. Then when it comes down to around 90, 92, 90, then it really slopes down and it becomes steep, and that's where it's becoming really dangerous. So especially because something you call pulse ox lack, which I'll shortly go into in a little while. But briefly, pulse ox lack is just that what the pulse oximetry is seeing is probably a minute late compared to what the brain is seeing. So we should and the solution to that is measuring the EtCO2, probably the end-tidal CO2 instead of this saturation only. But what I wanted to say here is that around 90, maybe 92, is where you when you intubate patients, that's where it becomes problematic to go on. Then you have to abort mission or get the tube in fast. This oxygen dissociation curve is famous and is like a physiology 101 thing, but I just wanted to point out when it comes to hop killers why pH is a problem. So one of the reasons why low pH is a problem is that it moves the dissociation curve to the right, making this much steeper. And when that becomes steeper, then there will be less O2 delivered to the tissues, and when and that in turn will create more hypoxemia, and therefore lower pH, and it'll become a evil circle that can spiral out of control. Of course, this is a complex system. It doesn't always hold true, but that's why we are afraid of low pH. What's the purpose of getting the tube in? Well, it is to protect the airway and maintain the airway, but also for respiratory failure. And then there are some minor things that, or not minor, but special cases, I guess, where, well, for status epilepticus, well, we have to sedate patients because of the GABA effects of propofol. If they don't stop seizing, there are humanitarian reasons. If they have pain that is uncontrollable, or if it's a really bad trauma, or so on. There's temperature control, there's neuroprotection, and there's minimizing metabolism. So there are certain minor things, but the main things are usually A and B problems. Maybe also the D, like the D problem, where you have definitely the D problem as well, but where you have a low GCS and that therefore you cannot protect your airway. Okay, the decision to intubate. All right, so when is there a obstructive problem or an airway problem? Well, so the highlights, which an ENT doctor told me once, were the triad, which is not always concurrent, but occurring at the same time, but dysphonia, hoarseness, or a hot potato voice. In Swedish, we might say grötig voice, like porridge voice. And if you have what we in Danish call spytflod, you're unable to swallow your saliva. Or if you have stridor is usually a quite late sign. The stridor can be inspiratory and expiratory and so on and so forth. And depending on your airway physiology, it might occur earlier than with others. But in general, stridor is always a thing to take seriously. It's doom about to happen. So these are the three things that we clinically should be aware of and think airway obstruction when we hear. Then there's the low GCS, which especially if it's going, GCS is always a thing that where you should ask, what's the delta? Is it going up or down? If you had a patient which just came out with convulsions and they're becoming better and better, even though they might have a low GCS now, they're going the right way. Then their airway isn't as problematic as if they're going down, or you have an intoxicated patient which is becoming worse and worse and worse. So the GCS is something that we often need a delta. You need more data points to be able to, or if it's a special context like you have a traumatic low GCS, then it's definitely something that is worth considering intubating, because it won't get better most of the times, depending on the reason for and so on. And then you have, then it's always important to think about this, that some A problems are not obvious. A problems doesn't always present with this, or the signal to noise ratio is really low, so you don't really hear these things. Especially if you have an older patient where there's a lot of noise in the picture, in the presentation. So A problems are not always obvious. Sometimes A problems develop because of B problems. So because you're so agitated and maybe you have a really tight stenotic trachea, but that's all right when you don't have a B problem. But when you get a B problem, then this becomes incompensated, and then you have a problem. So these problems usually can be disguised as each other or give problems to each other. So they, in my book, are kind of the same thing, or not the same thing, but in the same breath, we need to think about those. Then I wanted to talk about this this really important graph from Amy, the Amy book by Kovac. So when we stand in an emergency department and we are considering whether we should intubate or not, we could, there are certain situations or indications for this. So one of them is, well, there's a predicted clinical deterioration to one of the situations that we will mention above here, or it can be that we have to transport a patient. So if you need to go to the CT scan with a stroke patient, maybe their airway isn't a problem right now, but it's probably better to intubate them on the emergency room than in the donut of death CT room. It can also be whether, if you're working rurally, that you have a patient that needs to be transported somewhere and you rather secure the airway before it gets worse. A dynamic airway can also be the inhalation injury airway, or the bleeding airway, an airway that is slowly but surely becoming problematic, or is a high risk of becoming problematic, and where you want to intubate before rather than later. Then you have the indication to protect the airway, and as as this graph goes up, this is becoming more and more urgent. So if you want to protect the airway from aspiration, that might be your intoxicated patient, which is not going the right way GCS-wise, and who might be throwing up, and you don't have any reversible agents. Then you have the problem if you have a O2 problem or a CO2 problem, which cannot be fixed by just doing NIV, like BiPAP, or other measures. That might be your pneumonia patient or your COVID patients, where they have gas exchange problems that can be stabilized on a ventilator. It's important to know that, or to already now know that, well, when the patient is on a ventilator, then that doesn't fix the problem. That is something that keeps the patient alive, so the body, and with our treatments, can fix the problem, and then they can be extubated and they can have their body back. It's not something that cures the patient. So no matter what in this decision, we need to be able to think ahead and say, well, okay, is there a chance of this patient actually getting out of the ventilator? And that's why I think that's part of the reason why anesthesiologists want to keep the intubation thing on their fields, so to speak, so that they can contribute to this discussion. Okay, and then you have, and then there is to obtain and maintain the patent airway. This is your patient that is obstructing in front of you, or has a foreign body airway obstruction, or has an epiglottitis, and has stridor, which has a urgent A problem right now. Those you need to do something about the airway about right now. Okay, so this is the decision of whether or not we should intubate. Then we also have to weigh that against what is the risk of failure of intubation. So if the failure is unlikely, then it's all right. Then we can intubate always if we want to. But if failure is likely, then we have to weigh up the risks and benefits. If this patient with the inhalation injury also has anatomical problems, anatomical problematic airway, they also have this and that and third or fourth thing, then we should reconsider at least whether or not we should do this, or we need to optimize the first attempt with expert help. Maybe wait a little longer so that experts can arrive, so on and so forth. The hard situations is when you really have a failure is likely situation and you really need to do something right now. That's what I usually call penalty kick codes, because like in air quotes, no one expects you to save that patient. That's a penalty kick. It's amazing if the goalkeeper gets it, but in those situations, it's really hard to, no matter what you do, it's at odds with reality of what we're doing. It's sometimes that doesn't really always work out. Okay, so I want you to remember this picture when you're going through your code and why you should or should not intubate. This is what we want to discuss with the anesthesiologists. So let's look at why. Let's look at this, like the x-axis of that graph a bit more. How do we assess what the risk is of intubation? So let's just first talk about, will a successful intubation always have certain physiological changes? I just mentioned some of them here, but there's lots more. This is not a textbook explanation. This is more like a pragmatic explanation. But so you always have hypotension. Hypotension goes along with your induction agents. Some induction agents, and when we say induction agents, we mean the drug that we push to make the patient sleep, so that we can put a laryngoscope in and a tube into their airway. So that would be propofol or ketamine or some of the other drugs, etomidate, and all of these drugs will have the risk of producing hypotension. Vasodilation is specifically for propofol, and that's almost always that's a property of propofol, that it is also a vasodilator, so it will vasodilate and it will tank the blood pressure. But some people in emergency medicine have earlier said that, well, ketamine will not do this, but in general, you should always think about like the adrenaline drive that exists in a code patient, in a patient that is really in a bad way. They have a high adrenaline spike or high adrenaline level, and what you're doing when you give them an induction agent is that you lower that. You not eliminate, but you lower that significantly. So if that is what's keeping their blood pressure up, then no matter what kind of inductionation you're giving, that will give them hypotension. Just because it's an inductionation, it will reduce their adrenaline drive. So even ketamine, and I've been in a few situations with blood pressures of 200 and maps of way over 65, maybe 85, 90, where ketamine was given, and where the blood pressure fell down to below 65. So hypotension is always a thing, and as we will talk about when we talk about this benefits of intubation and risk of intubation, well, it's not a decision that always needs to be done right now, as you saw on the graph, and often the main thing is like resuscitate before you intubate is really a really important thing, especially if you can stabilize the situation and even improve it. It's when you can't improve it that there's a problem. That's where you have to make the decision before it gets worse. Okay. Then it will also increase intrathoracic pressure by basic physiology. The reason why we can breathe is because our diaphragm creates, when our diaphragm contracts, we create a negative pressure in our thorax, and that blows into our pulls air into our lungs. But when we are in a BiPAP machine or on a ventilator or are being back valve masked, then it's a different situation. That's the positive airway pressure thing, and when air is being blown into us, that means that the intrathoracic pressure is higher. And there's a few conditions where one of the main problems of the condition is that there's a high intrathoracic pressure, like a big pulmonary embolus or asthma, and these patients are patients that we really don't want to intubate if we really don't have to. Then there's the thing about HOP killers, which I alluded to. HOP killers are, again, hypotension, hypoxia, and pH, low pH. And these patients are patients that need lower doses of medicine, so lower doses of induction agents, and will have a problem with hypoxemia, even though they are pre-oxygenated and so on. So these are high-risk patients, and these are most of the patients that will have to intubate in a code situation. So there's always a risk of making the situation worse during intubation if we don't make the decision in a good way and don't think about the risks and benefits. Okay. And a lot of these risks exist in the RSI patient or in the patient where there's in the code patient. But if you go to the operating room, operating theater with elective patients, then it's not the same risks, and therefore anesthesiologists who only work in that environment may not always be aware of the details of this. And that's why we also, as emergency physicians, need to be able to discuss these things when they suggest that we give full dose propofol to a patient. And this is what Scott Weingart alludes to, and it's called propofol assassins. I think Cliff Reed has done that as well. Okay, so that was the harms when it goes well. What are the harms that we need to look out for, or the risks that we need to look out for during our assessment of risk in this? Should we intubate? Should we not? Balance act. And we could. George Kovacs has made this triangle where we think about, well, the anatomical risks, there's some physiological risks, and there are some psychological risks, which Cliff Reed has talked a lot about, and also Dr. Kovacs. And there's a video linked to his video about this here. Okay, so let's first look at anatomy. The thing is, there's no certain way of assessing a difficult airway. What will become an anatomical difficult airway? There's no 100% sensitive and 100% specific tests for that. So even though we think that our assessment is, oh, this is a problem-free airway, then most certainly we will come in situations, if we see enough patients, that, well, we will need exceptions to our assessment. And we don't have to look further than the tragic case of Elaine Bromley, That was the reason why the vortex method was made, as I believe, where a standard operation was done on a young woman, and I believe she got trismus during the intubation, or during the induction, and she became severely hypoxemic, and the doctors couldn't get an airway in, and they tried a lot of. There was a lot of errors as when you look at non-technical skills in that scenario, and just to summarize, the thing is, we cannot always assess whether or not this airway will be difficult or not. We cannot be totally sure, but if we do an assessment, we might have a better success rate of and be more prepared if we find an airway that's definitely a problem, anatomical problem. So there are different tools to assess this, and one of them, a popular one, is the one called Lemon. Look externally, evaluate the 3-3-2 rule. Can they open their mouth? Can they put 3 fingers into their mouth? Are there 3 fingers below, like below their chin, and then 2 fingers from the hyoid and downwards? Assess the melanopathy. Are they obstructive, or do they have obesity? And what is their neck mobility? And how fat is their neck as well? The American Association of Anesthesiology say, according to them, this is not evidence-based, but this is the only one which is evidence-based. It's very similar. This is what you call the Manoka score, and it's anatomical stuff, and then there's also some physiological stuff. And if you're above, I think, 3, then it's a difficult airway. There's also some features here when you do laryngoscopy, when you do BVM, LMA. There's the Lemon here. There's the on BVM, it's the bones mnemonic. On LMA, it's the rods, and so on and so forth. So the different of these, most of them go through these, some of the same of these. So usually, if you do the melanopathy, look at how fat their neck is, and look if they can open their mouth. Then usually, those are some of the most important stuff for the anatomical description. Okay, so that was the anatomical risks of the patient. So then we'll go to the physiological risks, and here I've also said like fasting and reflux disease, which are like common things that anesthesiologists are always aware of, and maybe over aware of. If you look at the PSA lecture of Ruben Strayer, he proposes some evidence. He puts forward some arguments about the real risks of actually fasting, aspiration, and so on. But I think it's safe to say that this is something that also has to be taken into account when you do your assessment, and whether or not they've been fasted, and that's traditionally one of the main reasons for doing what you call an RSI, as we will come to in a little bit. And then there's also, as we talked about, the physiology of the condition of the pathology that they have right now. If they have asthmatic, or they have pulmonary embolism with a high intrathoracic pressure, then that's a physiological marker that you need to take care of or be aware of. And then there's always the generic hop killers, hypotension, hypoxia, and pH. That are really important to think of. So the hop killers are, as we already talked about, a mind child of Scott Weingart. And the hypotension problem is usually when you give drugs, then, as we said, the drugs, the induction agents, will make the hypotension become even worse. So you need to even pre-medicate with noradrenaline or resuscitate before you do anything, and also choose your right drug and the right dose. The dose is probably more important than the drug, and usually you can give it in incremental doses. Sorry, instead of one push dose. Also, there are Scott Weingart usually talks about in his lectures the laryngoscope as a murder weapon. He talks about like what do you actually want to achieve when you sedate patients, and his argument is that you cannot achieve all of these things as you would in the operation room, because you have to sedate them a bit more shallow, otherwise you will tank their blood pressure. And he usually tells a story that when he was a resident in the shock and trauma center, sometimes they would have patients say, "Oh, I think I remember when I got intubated," and one of his, his colleagues and one of the people who he looks up to, one of his mentors, he usually talked with the patient and said, as a response to their question, "Well, I think I was awake there." Then they would often respond like, "Oh, thank God that you were awake. Well, thank God that because we thought you were dead." And it like kind of gives you the picture that if you come in a really bad way, we want to try to save your life, and that might compromise the comfortability of sedation and intubation as compared to what you would achieve in the operation theater. But if it means that we can save your life, then it's probably better to sedate a bit shallower. That's the argument. Okay, then you have hypoxemia or hypoxia. And the thing about hypoxia is that, well, as we will come to, pre-oxygenation is really important before you go into your induction. You need to fill the lungs with air, with oxygen. And you need to remove all the nitrogen so that more oxygen can come in. That's the purpose of pre-oxygenation. The worse a patient is, and if they're a child with a high metabolism, if they're fat, if they have high metabolism because of sepsis or so on, then the apneic period when you give them the drugs and when they don't breathe anymore, where the pre-oxygenation should be the one thing keeping them alive and keeping them saturated, that like margin, that time window is much narrower and when you have a HOP killer patient. Patients with hypoxemia is a high risk, especially if you can't pre-oxygenate them up to a level that is good. If they, despite pre-oxygenation, keeps being well below 90, that's really a bad thing, and that's why it's a killer as well. And then you have low pH, which I alluded to. That's like an evil circle going low pH, then hypoxemia, then low pH, and hypoxemia. And that's why DKA patients are usually some of the most sour patients. Like they have pH of 6.9 sometimes. Those are the ones that you probably don't want to intubate if you really don't have to. Okay, all of these HOP killers, that doesn't mean that you shouldn't intubate the patient. It just means that you need to reduce your doses. You need to have a different approach to these patients, compared to operation theater patients. And I just wanted to show, this is from the Vortex Approach YouTube channel. So when you do a intubation, you might do a DSI, which is a sedation, so that you can pre-oxygenate the patient. Delayed sequence intubation it's called, or delayed sequence induction. You might do a DSI if you're really motor agitated, so that you can do the procedure, which is pre-oxygenation. But that's something that you don't always do. But you will pre-oxygenate before your RSI, your rapid sequence induction. And when you do that, then you have this when you pre-oxygenate, then you hope you have this time to critical desaturation. That this is really, really long. That's the purpose of pre-oxygenation, right? They don't fall below maybe 90% or in saturation, as we talked about earlier. And what you want is that your time to your non-surgical airway, like your intubation tube, the time until you find the hole, you get your tube in, is well before they get to critical desaturation. We might call this the safety margin, this time window we have. Okay. What happens, as we talked about, if you have an obese patient, if you have a pregnant patient, if you have a patient, a child with a high metabolism, if you have suboptimal pre-oxygenation, if you have current illnesses that keeps the patient from getting their sats up, if you have hop killers, then this window decreases. This time to critical desaturation decreases, and the safety margin decreases as well. Especially if your attempts at intubation becomes more than just the first pass success attempt. So you can see that in a critical situation where you have all of these factors, or some or all of these factors, and you have a difficult airway where you might not get it in the first try, then you will get this critical desaturation, which is what leads to death and cardiac arrests. So this is one of the main slides in the risk assessment. This is really important, and why we should always have plan A, B, and C, and should not fiddle around with stuff until the sats are really low. We should get on moving, and have a plan before and apply that plan and before it gets too late. So that's part of that's a little prelude to the vortex approach. Okay. Yeah, some of the factors that might prevent us would be anatomical factors or ST factors, which I will come to now. Because here in the psychological area, we have the psychological difficult airway, and the psychological difficult airway is I've based on this STE concept, which is Cliff Reed's brainchild. He has some lectures on this called the 0 Point Survey, and also a paper on it. And the thing is, self, that is ourself. How are we feeling? Have we done this before? Are we stressed? Are we cognitively loaded? Have we peed? Are we emotionally where we should be? Are we tired? All these factors are important. So if you have this kind of heart intubation, anatomically and physiological heart intubation, difficult intubation in the middle of the night when you haven't slept, then this is a really important factor, and maybe a reason for why you shouldn't do it, or maybe you have a colleague who can do it instead. Or maybe you can optimize by what you call beat the stress fool techniques. Breathe, talk to yourself, see, visualize, and focus. And this is Mike Loria who's made this BTSF technique that I've talked about in several videos already. Then you have your team. You need the best team for the task. So if you need to wait for your anesthesiologist expert, then you have to wait for them if you can wait, and usually you can. You need the right equipment, so you need video laryngoscopy if it's a difficult airway, and so on and so forth. So these psychological factors are really important. We might call them human factors as well. And I've made several videos on these, so I won't go into details with this, but this is also part of the risk assessment. And here are some of the links for some of the international lectures on this. And as I said, I have made a video called Probabilistic Neurology, where I go into this in details about this. Okay. And part of this is also, we get, this is from Hicks as well. This is just another way of saying this, like we can be stress overloaded when we have a lot of input and we appraise the situation as being demanding. Compared to the amount of resources that we have, then our output will, like if we appraise the situation, if we don't have any resources, then this will be a huge problem. This will give us physiological and emotional and cognitive behavioral stress, which will make us not be able to do things as well as we could. And what you need to do in such a situation is try to gain resources by, like, psychologically doing some of the things, tricks that you can do. But before the situation occurs, you have to do these STE things as well. Gather your equipment, gather your team, and like talk yourself through the procedure. Visualize, like brief BTSF. And also before going into the situation, you should simulate. And so I've done this before. Okay, I can do this. Only practice one thing, as Scott Weingart said. Don't practice several things if it's a procedure that you don't, you're not going to do a lot of times in your life. So yeah, this is a great model for storing this kind of demand resource and how we can change this balance during a stressful situation by knowing what to do. And here was this is the BTSF, if you want to look at this. Okay, so now we have the complete model of this decision to intubate and what the risk assessment is. So we have what is the indication here and how urgent is it. And of course, some of these indications are much more urgent than others. And how likely is it to fail? And that was the slide with the triangle, and also the inherent problems with successful intubation. Okay. So it's always about striking this balance, and the mantra is always resuscitate before you intubate. Almost always you can position the patient better. You can do basic airway maneuvers. You can optimize the hop killers with fluids, with blood if it's a trauma. You can decompress any pneumothoraxes if there's a high intrathoracic pressure. You can put in IVs. You can get the video laryngoscope. Almost always you can do some of these things to optimize. It's important to like almost always resuscitate before intubate. That's one of the main take-home messages. And there's really few situations where that doesn't hold true. So there's this mantra in ATLS called GCS of 8, then intubate. And like most things in ATLS is made for the general population of doctors in all countries. It's not made for emergency physicians specifically. So there is some truth to, well, if the GCS is below 8, it might as well be 9 or 7. In a trauma setting, then yes, then you should consider intubating. And most times that doesn't have to be right now. It has to be within minutes, maybe hours. It depends on the situation. Intubation might not be the highest priority. You just have to think about it. But I think the problem with GCS 8 intubate is that it becomes dogma and becomes something that doctors tell like older doctors tell the new doctors, oh, you should always intubate when the GCS is below 8. I just wanted to quickly say that no, that is not true. You have to consider the delta of GCS. Is the GCS going up or is the GCS going down? Sometimes you don't know, but in a status epilepticus patient, where you, or sorry, not a status, but if you have an epileptic patient, they are often GCS of 3 after they come out of their seizure. And you have to give, and oftentimes, iatrogenically, we have given them midazolam or and some kind of other benzodiazepine, even though they might not have needed it. I'm not saying you shouldn't give benzodiazepines, but sometimes we are probably a bit too quick. Most seizures stop within 2 or 3 minutes, but if we give them too early and too high a dose, and then before we know whether we actually need to do something about it medically or whether it will terminate by itself, then we often will sedate the patient and they will not come out right away of their post-ictal period, and we get in the situation where you have a patient that just has stopped seizing, but they have a problem with the airway and they don't emerge from their post-ictal period as they were expected to because of the benzodiazepine on board. And in this situation, well, you have a GCS of 3, oftentimes maybe something like that, but they are ABC stable and they are going upwards, especially if they gave them a slower benzodiazepine with a shorter half-life like midazolam. So in such a situation, even though GCS of 3, they're going up, and you are at the bedside trying to help them. If they do throw up or do any other things that harm the airway, so in such a situation, it's a case-by-case discussion. Also, your intoxicated patients. Well, some intoxicated patients just ingested their thing and are going down, and you can expect that they will be going down. And that's a problem if you don't have any reversible agents. That's the situation even if they GCS of 11 or 12. Then because of the delta and because of the expected worsening of the patient, then you would intubate anyway. But if you have and sometimes you have the patient of a GCS of maybe 3, and then they're actually going up because, well, it was maybe 8 or 10 hours before since they did it, since they ingested, and they've become slightly better. They're keeping they're managing their ABCs. Well, then maybe you don't have to intubate those. I know this is not evidence-based, this is usually religion, and we all practice differently, but we have a lot of experience with these patients because of our location in Stockholm, right next to the addiction clinic. And just something to consider. The take home of this is like, always think of the delta. Are they going up or going down when you think of intubation? And is the cause of their problem reversible or not? Well, if they're going down and it's irreversible, then you should probably think of intubation. If they're going up and it's or if it's a reversible thing, like they are taking morphine, then you can give naloxone. Then you should probably not think about intubation right away. Okay. Okay, here I just made a 2x2 table showing that, well, what I just talked about. GCS going up or stable, GCS going down, and here are the reversible course or irreversible course. So if you have a stable patient or a GCS going up and it's a reversible course, then usually you don't have to do anything. That might be an intoxicated patient that is becoming better, or a post-ictal patient that is becoming better. If however the delta is going down and is a reversible course, then you should probably think about reversing the thing. Most often that would just be giving naloxone to a patient, usually giving not 0.4 milligrams, but maybe giving 1/10 of that, and giving it in incremental doses so that they don't just run out of the department. Or giving it double dose intramuscularly, like 0.8 milligrams, unless they use buprenorphine or something like that. Then you have to go up in higher doses. Always look for the response in terms of GCS, respiratory frequency, saturation, PCO2. All right. Because as I reminded you, you don't want that PCO2 to go too high up, because that would make you get a pH problem, which would give you into the evil spiral of pH and hypoxia. Okay. If you have the delta GCS going up and you have an irreversible course, then sometimes usually you can give it a bit of time. You can try to resuscitate a bit more and then intubate later if you need to. But they will need some kind of intubation now or later. So but usually you can improve the patient before you have to intubate them then. If you have a delta GCS that is going down, and it's an irreversible course, then usually you have to intubate them now rather than later. And then it's a matter of what the other priorities are right now. Maybe it's a trauma where you have both a epidural hematoma and you have hypotension because of a bleed somewhere. Then maybe you want to get them blood before, but there's a low list of priorities that are more important than getting the tube in then. As opposed to in this situation where you can have a long list of priorities before getting a tube in if they're doing good. Okay, and this might be your epidural hematoma where you need to, well, they're not getting any better and their GCS is going down. They need to be intubated now. Okay, it might also be your pneumonia. They're not getting better, like severe pneumonia where you have like 15 liters of oxygen. And they're really in a bad way. Well, they're not getting better. You might be able to give them a little bit of resuscitation or a lot sometimes. But if they're becoming worse and worse, then you don't have much choice then to do something now. So always when it comes to GCS and the GCS of 8 intubate, think of the delta and think of what kind of situation you're in. Is it reversible or irreversible? And almost always you have time to resus before you intubate. Okay, this is it for the first part of this lecture, and then in the next part we'll go through the basic airway maneuvers and vortex model.